Today's lecture is prematurity, anatomical and physiological features, postnatal adaptation of premature baby. In different countries, the frequency of prematurity constitutes from 3.6 to 25%. 1.1 million preterm babies die every year, but with inexpensive treatment 75% could survive. Prematurity is the most frequent causes of perinatal and infant mortality, about 60% of stillbirths, 50 to 70% of early neonatal mortality, and 40-66% on infant mortality. Proportion of premature delivery in Ukraine constitutes about 5%. Each year, some 15 million babies in the world, more than 1 in 10 births, are born too early. More than 1 million of those babies die shortly after birth. Countless others suffer some type of lifelong physical, neurological, or educational disability, often at great cost to families and society. Life prognosis for premature baby infants directly depends on the gestational age and birth weight. What does it mean, premature baby? Live-born infants delivered before 37 weeks from the first day of the last menstrual period are termed premature by the World Health Organization. You see on the picture, it's a premature infant. Note how small he is compared to the hand. Before prescribing detailed facts, we must know terminology of prematurity. It's not so interesting, but it is obligatory to know. Late preterm, those born between 32 and 37 weeks, account for 84% of total preterm births, or 12 million. Most survive with supportive care. Very preterm, those born between 28 and 32 weeks. These babies require extra supportive care. Most will survive. And extremely preterm, those born before 28 weeks. These babies require the most intensive, expensive care to survive. In developed countries, these babies have a 90% chance to survival, so they may suffer lifelong physical, neurological, and learning disabilities. In low-income countries, only term survive. Term newly born infant, a live baby born in the term of gestation from 37 complete weeks to the end of the 42nd week of gestation. Overterm, or you can meet in the book post-term, newly born infant, a live baby born after 42 complete weeks of gestation. Large for gestational age, the birth weight greater than 90% of percentile for gestational age. Small for gestational age, the birth weight less than 10% of percentile for gestational age. And classification of weight premature baby. Normal birth weight, yes, it's 2.5 till 3.9 kilograms, and low birth weight up to 2,500 grams, very low birth weight less than 1,500 grams, and extremely low birth weight less than 1,000 grams. There are many reasons of prematurity, risk factors of prematurity. So, survival level of premature newborn infants depends on social, economical conditions of life, food quality of the pregnant, the quality of obstetrical observation and aid, level of medical establishment, place of birth, sex, race, multiply of single pregnancy, and level of medical aid for the newborn. Pay attention about clinical causes. It's a fetal anomalies, congenital infections, chromosomal disorders, extragenital disease of the mother, chronic urinary disease, endocrine pathology, cervical and placental insufficiency, so on. On this picture you see preterm infant on the left, picture A, and term infant on the right. You see difference between it. Now, in detail, I want to speak about premature infant. On this table you see the preterm infant compared with the term infant. It's very easy to remember. The premature infant is small, usually weighing less than 2.5 kilogram. Baby in term has in average 3.5 kilogram. Premature infant tends to have thin, shiny, pink skin through which the underlying veins and are easily seen. Little subcutaneous fat, hair, or external ear cartilage exists. Spontaneous activity and tone are reduced, and extremities are not held in the flexed position typical of term infant. In males, the scrotum may have few rugae, and the testes may be undescendant. In females, the labia majora don't yet cover the labia minora. About growth, preterm infant have rapid growth. For example, preterm infant and 28 weeks gestation double their birth weight in 6 weeks and treble it in 12 weeks. There are several transient conditions. For baby in term, there are many transient conditions in physiological situation, and we must know about it to differentiate from pathological. For premature baby, we have physiological jaundice extends to 3 weeks, not to 2. High bilirubin level encephalopathy may occur even the bilirubin level is not only high and needs treatment. Physiological erythema extends to 2 weeks. Physiological weight loss is from 9 to 14%. Toxic erythema, hormonal crisis, transient hypothermia are absent in premature baby. So, gestational age and methods for its determination. You must know it. Why? Because it's important to know what is gestational age exactly. There are perinatal obstetrics and postnatal pediatrics methods for determining gestational age. You can use history, the result of objective obstetric examination, and the result of ultrasound examination. You can use ultrasound examination during pregnancy. You can use analyzing the data and something else. Postnatal methods of assessment of gestational age include point systems using criteria of external and neuromuscular maturity. Such system includes the Dubowitz-Ballard-Parkin scales, but the most modern and currently used is the new Ballard scale. This scale allows to determine the gestational age of a child in the range of 20 up to 44 weeks. However, the most accurate for the gestational period is more than 28 weeks. So the new Ballard score is a set of procedure developed by Dr. Jean Ballard. You see the picture of this doctor. And this doctor create two tables: neuromuscular maturity and physical maturity. You will see this ballard on the Learn platform. You will speak in detail about this ballard on practical classes, so please pay attention and see at the Learn system. Next one. The incidence and severity of complications of prematurity increased with decreasing gestational age and birth weight. Some complications, necrotizing enterocolitis, retinopathy of prematurity, bronchopulmonary dysplasia, intraventricular hemorrhage, are uncommon in late preterm infant. Most complications relate to dysfunction of immune and immature organ system. In some cases, complications resolve completely. In others, there is residual organ dysfunction. So on this picture, in short, you can see complications early and late. The first of all, we pay attention about thermal control. Why? Because hypothermia causes increased energy consumption and may result in hypoxia and hypoglycemia, failure to gain weight, and increased mortality. It's a very important point. Preterm infants are particularly vulnerable to hypothermia as they have a large surface area related to their mass, so there is greater heat loss than heat generation. Their skin is thin. They have little subcutaneous fat for insulation. Respiratory system. Pay attention about respiratory distress syndrome, pneumothorax, apnea, and bradycardia and desaturation, bronchopulmonary dysplasia. We start from respiratory distress syndrome. In respiratory distress syndrome, also called hyaline membrane disease, there is a deficiency of surfactant, which lowers surface tension. Surfactant is a mixture of phospholipids and proteins extracted by the type II pneumocytes of the alveolar epithelium. Surfactant deficiency leads to widespread alveolar collapse and inadequate gas exchange. The more preterm the infant, the higher the incidence of respiratory distress syndrome. It is common in infants born before 28 weeks gestation and tends to be more severe in boys than girls. Surfactant deficiency is rare at term but may occur in infants of diabetic mothers. Glucocorticoids given antenatally to the mother stimulate fetal surfactant production and are given in preterm delivery is anticipated. The development of surfactant therapy has been a major advance. The preparations are natural, derived from extracts of calf or pig lung. They are instilled directly into the lung via tracheal tube. At delivery or within 4 hours of birth, babies with respiratory distress syndrome develop clinical signs of tachypnea, more than 60 breaths at a minute, labored breathing with chest wall recession, particularly sternal and subcostal indrawing, and nasal flaring. Expiratory grunting in order to try to create positive airway pressure during expiration and maintain functional residual capacity. Cyanosis if severe. To diagnose, we can do chest X-ray. Treatment with raised ambient oxygen is required, which may need to be supplemented with continuous positive airway pressure (CPAP) or artificial ventilation via tracheal tube. Next one is apnea. Apnea of prematurity is defined as respiratory pauses more than 20 seconds or pauses less than 20 seconds that are associated with bradycardia. What does it mean, bradycardia? It beats per minute less than 100. We can see central cyanosis and or oxygen saturation less than 85% in neonates born at less than 37 weeks gestation and with no underlying disorders causing apnea. Cause may be central nervous system immaturity, central apnea. If the episode of apnea is prolonged, there may be a component of airways obstruction as well. Diagnosis is clinical and by cardiorespiratory monitoring. Treatment is with respiratory stimulants for central apnea and head position or head positioning for obstructive apnea. Prognosis is excellent. Apnea resolves in most premature neonates by 37 weeks and in almost all premature infants by 44 weeks postmenstrual age. Bronchopulmonary dysplasia. We can call it as chronic lung disease. Infants who still have an oxygen requirement at a postmenstrual age of 36 weeks are described as having bronchopulmonary dysplasia or chronic lung disease. The lung damage comes from pressure and volume trauma from artificial ventilation, oxygen toxicity, and infection. The chest X-ray shows widespread areas of opacification, sometimes with cystic changes. Some infants need prolonged artificial ventilation, but most are weaned onto continuous positive airways pressure, CPAP, followed by additional ambient oxygen, sometimes over several months. Corticosteroid therapy may facilitate early weaning from the ventilation and often reduces the infant's oxygen requirements in the short term. Next situation, we can see infection. It's common and potentially seriously in 25% of premature baby. Sepsis and meningitis is about 4 times more likely in the premature infant, occurring in almost 25, as I already had said, of very low Brightway infants. Preterm infants are at increased risk of infection, as immunoglobulin G is mostly transferred across the placenta in the last trimester and no immunoglobulin A and M. In addition, infection in or around the cervix is often a reason for preterm labor and may cause infection shortly after birth. Most infections in preterm infants occur after several days of age and are nosocomial or hospital. They are often associated with indwelling catheters or artificial ventilation. Infection is considered in more detail later in this chapter. Next one, it will be metabolic disorders. You can speak about hypoglycemia, that is common for premature baby, and some electrolytes disturbance. So, the first of all about hypoglycemia. It's so common for premature baby and is difficult to define in neonates. for the first time, but is generally considered a serum glucose concentration less than 40 mg per deciliter. It's less than 2.2 millimole per liter in symptomatic term neonates, less than 45 mg per deciliter, less than 2.5 millimole per liter in asymptomatic term neonates between 24 hours and 48 hours of life, or less than 30 mg per deciliter, less than 1.7 millimole per liter in preterm neonates in the first 48 hours. Risk factors include prematurity, being small for gestational age, maternal diabetes, and perinatal asphyxia. The most common causes are deficient glycogen stores, delayed feeding, and hyperinsulinemia. Signs include tachycardia, cyanosis, seizures, and apnea. Diagnosis is suspected empirically and is confirmed by glucose testing. Prognosis depends on the underlying condition. Treatment is enteral feeding or fordextrose. Next one will be hyperbilirubinemia is physiological jaundice. For mostly cases, it's physiological jaundice, but for premature infants tends to be visible early, even on the first day of age. Weeks later, 5 to 7 days of age, and may take up to 2 weeks to completely resolve. Most extremely low birth weight infants require treatment. Even level of hemoglobin is normal, as for term baby. Infants at high risk for kernicterus at levels of bilirubin far below those is more mature infants may have deafness, mental retardation, and cerebral palsy. What about treatment? The first of all is phototherapy. You know that we can use special blue lamps. Phototherapy breaks down unconjugated bilirubin to a more water-soluble product via photoisomerization and photooxidation through the skin. About this in detail we will study through several classes. Next situation, necrotizing enterocolitis, is a serious illness mainly affecting preterm baby in the first few weeks of life. It is associated with bacterial invasion of ischemic bowel wall, but the exact cause of necrotizing enterocolitis is unknown. Preterm infants fed cow's milk formula are more likely to develop this condition than if they are fed only breast milk. It typically occurs within 2 weeks of birth and presents as feeding difficulties, abdominal swelling, hypotension, and other signs of sepsis. We can provide radiographic examination and can find stucked bowel loops, pneumatosis intestinals, so we can see presence of gas in the bowel wall. Infants are treated with antibiotics and bowel rest. Next situation, retinopathy of prematurity. Retinopathy of prematurity affects developing blood vessels at the junction of the vascular and non-vascularized retina. There is vascular proliferation which may progress to retinal detachment, fibrosis, and blindness. It was initially recognized that the risk is increased by uncontrolled use of high concentration of oxygen. But now, even with careful monitoring of the infant's oxygenation, retinopathy of prematurity is still found in about 35% of all very low birth weight infants. As retina-reduced visual impairment, the eyes of susceptible preterm infants are screened every week by an ophthalmologist. Severe bilateral visual impairment occurs in about 1% of very low bright weight infants, mostly in infants of less than 28 weeks gestation. Next complication, it's patent ductus arteriosus. It's a persistence of the fatal connection between the aorta and pulmonary artery after birth. In the absence of other structural heart abnormalities or elevated pulmonary vascular resistance, shunting in the patent ductus arteriosus will be left to the right. Symptoms may include failure to thrive, poor feeding, tachycardia, and tachypnea. A conditions murmur at the upper left sternal border and bulging pulses are common. Diagnosis is by echocardiography. Administration of the cyclooxygenase inhibitor. It can be indomethacin with or without fluid restriction may be tried. So in full-term newborns, the patent ductus arteriosus typically closed within 48 hours of birth. But 80% of early extremely low birth weight infants have a clinically significant PDA, resulting in a left-to-right shunt that causes a variety of symptoms. And last complication of prematurity that we speak about is preterm brain injury. Hemorrhages in the brain occur in 25% of very low bright weight infants and are easily recognized on cranial ultrasound scans. On this picture you see ultrasound scan on coronal and sagittal scans. You see that it's white hypoechoic region that is showed by narrow. It's a hemorrhage. It's a hemorrhage, but not so big. It's hemorrhage grade 2. Typically, they occur in the germinal matrix above the caudate nucleus. And most hemorrhages occur within the first 72 hours of life. They are more common following perinatal asphyxia and in infants with severe respiratory distress syndrome. Pneumothorax is a significant risk factor. Small hemorrhages confined to the germinal matrix don't increase the risk of cerebral palsy, if you see on this picture. But hemorrhages may occur in the ventriculus. It's a CT scan, and you see white region, hyperdensity, yes, and it's hemorrhage into the ventricles. The most severe hemorrhage is unilateral hemorrhagic infection involving the parenchyma of the brain. This usually results in hemiplegia. About half of infants with progressive post-hemorrhagic ventricular dilatation have cerebral palsy. Except of the hemorrhage, we can see in premature baby periventricular white matter brain injury. This injury may occur following ischemia or inflammation and may occur in the absence of hemorrhage. It is more difficult to detect by cranial ultrasound on the first day after birth. Why? Because sometimes we can see only hyperechoic regions. Initially, there may be an echodense area or flare within a brain parenchyma. This may resolve within a week. Sometimes it's a sign of hypoxia, and in which case the risk of cerebral palsy is not increased. But if cystic lesion become visible on ultrasound after 2 weeks of birth, there is defined loss of white matter. Then periventricular white matter brain injury is present. Bilateral multiple cysts called periventricular leukomalacia have an 80-90% risk of spastic diplegia, often with cognitive impairment, if posteriorly sighted. Both intraventricular hemorrhage and periventricular leukomalacia may occur in the absence of abnormal clinical signs.